رب إنهن أضللن كثيرا من الناس فمن تبعني فإنه مني ومن عصاني فإنك غفور رحيم ربنا إني أسكنت من ذريتي بواد غير ذي زرع عند بيتك المحرم ربنا ليقيموا الصلاة فاجعل أفئدة من الناس تهوي إليهم وارزقهم من الثمرات لعلهم يشكرون ربنا إنك تعلم ما نخفي وما نعلن وما يخفى على الله من شيء في الأرض ولا في السماء الحمد لله الذي وهب لي على الكبر إسماعيل وإسحاق إن ربي لسميع الدعاء صدق الله العظيم.
Jazakallah. Assalamu alaikum and good morning, ladies and gentlemen. Welcome to the 7th Hands-on Colonoscopy Training course. This course is one of the series of the courses that this unit has undertaken to improve the quality of basic and advanced endoscopy training in our country. The main purpose of this course is actually not to reform you or to make you expert technicians, but just to widen your horizons and help you think how to make yourself better. Always remember that once you find yourself amongst the crowd, always try to stop and think and ponder and reflect on how to make yourself stand out amongst the crowd. And this is what we are hoping to achieve by organizing these workshops. We are very fortunate to have amongst us a very learned and outstanding faculty for this course. Before I introduce the faculty, I would like to request our professor and chairperson, Faculty of Surgery, Dow Medical College, and Medical Superintendent, Civil Hospital Karachi, Professor Sept Qureshi, to please come and welcome you all.
Assalamu alaikum, ladies and gentlemen, Paul, Waqar, Janet. This is the 7th colonoscopy course, and concurrently we also run ERCP courses, and we have done 3 of those. And I welcome you all, participants and observers, to this 7th colonoscopy workshop. I hope it will be instructive and you will acquire, or if not acquire, at least polish up your skills of colonoscopy and correct any bad habits that you may have learned on the way. I would like to thank Paul, who has been helping us out over the last few years, Waqar, who has been here even longer, and Janet is accompanying for the second time for this workshop. And I would like to express my gratitude to them for all of their help and consideration. They take the time out, travel from the United Kingdom to Pakistan, and not only help us out, but help all of you in acquiring the skills. Thank you very much.
Thank you very much, Dr. Saeed. As far as the faculty is concerned, there are actually 2 kinds of teachers. One are the kind who would just give you a quell shot and you wouldn't know how to move. And there's another kind who would just inspire you to start doing things and to make yourself different from the others and to stand out amongst the crowd. So we are very lucky to have such sort of faculty with us. And we have, first of all, Dr. Waqar Ahmed, who is a consultant physician and gastroenterologist at Gannett Hospital, UK. Thank you very much, Dr. Waqar, for coming. Paul Hagan is a consultant endoscopist at Kingsmills Hospital, Mansfield, Nottinghamshire, UK. He's not just an excellent teacher, but a very nice person. And Dr. Waqar also comes in that category. So thank you both of you. Now I would like to request Dr. Waqar, who is also one of our course directors, to please come and give a brief introduction of the course, and then he'll be talking about the indications and contraindications of colonoscopy.
Assalamu alaikum, and thank you very much, Sajida, and Professor Saeed Qureshi, for your kind introduction. It's always a pleasure to come back to Karachi. It's like a second home to me. Though I come from Peshawar, but Karachi is a second home, and this department is my home department. Right. There's a bit of a history. Normally, this introduction is done by my colleague, Dr. Saad Niaz, who is a bit incapacitated at the moment. I think he's busy somewhere else. So I'll be doing the introduction badly. It was a few years ago that we decided to embark on this course because there was a great need for it. And it took a lot of logistics, a lot of thinking, a lot of brainstorming to come up with that. We came out with the ideas, but all the hard work was done here in this department, starting from Dr. Sajda, from Shariar, and no doubt we had always the backing of Professor Saeed Qureshi, who has always been very supportive. So this is a major effort, and it has come to fruition because now, alhamdulillah, this is the 7th colonoscopy course that we are running. We've done 3 RCP courses, all very successfully. And just to give you an idea of what you are letting yourself in for, there are, I think, about, what is it, 6 or 7 centers in UK that run colonoscopy courses like this. And this course is exactly run on the same pattern as the one in Wolverhampton. In UK, we call it the Basic Skills Colonoscopy course. It is mandatory for all specialist registrars who start their gastroenterology training to undergo this course. Without this course, they cannot progress. So this, in a way, is an entry course. It's not an exit course. It does not make you masters of colonoscopy. It guides you in the right direction. And once you've attended this course, we expect you to work in a department where you are working under supervision, under an expert who can guide you further. Because 3 days is not going to make you a master of colonoscopy. I still continue to learn every day. So you need to confirm, because we've had people who were under the impression that they can set up their own department. They cannot. For their own safety, for their patient safety, you need to still work. So that is something which we like to make very clear. In UK, when we run these courses, we only have 4 candidates. Here, we've been a bit more generous and we've taken 5 candidates on. But as it is amazingly oversubscribed, we have taken on observers as well. With observers, they are going to be observers. We do not give them hands-on with patients. If time allows, they can get some hands-on experience on the models. But they should know where their expectations are. But for future courses, they would be given preferential treatment. So they would get, be considered for future courses. The way it works out is, I'll start off with the boring stuff, which is the theory, the indication, contraindication, the consent process. We need to cover those because that is important. Once we've done that, then we'll start with the real action. And Paul will lead on the action first, and then we take it in turns to take you on with us, once you've worked on the dummies and the models, to take on the real patients. So it will be, I hope you all enjoy it. It's going to be fun. And I'm sure, the other thing which we really encourage is that this is not just a lecture or a demonstration. It has got to be an interactive process. We want full participation from yourself. At any time during the lecture, during the demonstration, please feel free to chip in. No question is stupid or irrelevant. If it is unclear in your mind, please ask, because this is the opportunity you get, to ask or discuss it and get it clear in your mind. So don't feel shy about it. At least I'm not a professor, I'm not anyone very important or VIP, so you can talk to me just like, your elder brother, and Paul doesn't mind either. So please take the maximum out of it by interacting with us, okay? Because I know initially when you start the course, there's always a bit of reluctance, and then everyone joins in. So we want you to do that. I think that's probably about it. Now, I think we'll start off with introduction. Yeah, that's another thing which I was missing. I told you I would do it badly because Saad does it very well. Now, can I ask everyone to introduce yourself and tell us whether you are doing the actual doing the course hands-on or observer. So just say.
I'm Dr. Khurram Malik from Fatma Memorial Hospital, Lahore. I'm a postgraduate resident in GI department, final year, and I'm candidate for the hands-on workshop.
Okay. So, Khurram Ali, yeah?
Yeah.
You are with Arif Amin.
Arif,
Fine, okay, good. All right.
Assalamu alaikum. I am Dr. Yasir Abbas Zaidi. I was a postgraduate resident 6 months back at Sheikh Zayed Hospital, Lahore, under the supervision of Professor Rashid Kamal Bhatt and Professor Taaf Alam. Currently working as Admin Registrar, Gastroenterology Department, Nishtar Hospital, Multan. I'm here for the hands-on course.
Okay, good.
Assalamu alaikum. I'm Dr. Salman Afzal, and I'm finally resident in Sheikh Zayed Hospital Gastroenterology Department under supervision of Dr. A.K. Bhatt and Altaf Alam. And yes, that's it.
Sorry, where is that?
Sheikh Zayed Hospital.
Oh, Sheikh Zayed, yes, of course, in Lahore, yes, yeah. Fine, okay, yeah.
I am Dr. Majid Sheikh. I am working as Assistant Professor of Medicine at Janka Medical College, Ladkana. I am the candidate for hands-on.
Right, okay, thank you.
Dr. Yasir Abbas, PG Gastroenterology, third year in Shifa International Hospital, under Dr. Fazana Shafqat, and I'm here for the hands-on workshop.
Shifa in Islamabad?
Yes.
So you work with Najam Shah?
Yes.
It's okay. Okay.
Hello, I'm Dr. Kiran Naz, and I'm working here as surgical resident year 3, and I'm here for the observership.
Okay, fine.
I'm Dr. Arif Prakash, pediatric gastroenterologist, and I have trained from Lahore, from Children's Hospital under supervision of Professor Humar Shah Chima. Now I have started a new unit at NICH Karachi, and I am alone there. Just came here to attend that course to improve my skills further.
Right.
Good morning, everybody. I'm Dr. Munira. I'm working as an AP in General Surgery Department at Hamdard University Hospital. I'm here today for the observer status.
Right, okay. Thank you. I think there's some candidates in the back. No? Right, okay. Right, thank you very much. I think, is that it? Yeah. We start with lectures. Depend on the Sharia for that.
इधर से आ जाए अच्छे लगे
हो गया ठीक
ये पॉइंटर है इसका ओके सॉरी
उधर कुछ और आ रहा है
आएगा
Okay, fine. Yes, sir.
My name is Dr. Yahya Afzal, and I'm doing my second fellowship in gastroenterology in Sheikh Zayed Hospital, Lahore.
Okay,
thank you.
Thank you.
फॉरवर्ड बैक करके देखिए
कौन सा ये
बैक हो रहा है ये फॉरवर्ड एंड पॉइंटर उसके ऊपर है ये पॉइंटर
राइट ओके थैंक यू अच्छा ठीक है राइट ओके राइट my IT skills are quite poor, so that's why I'm totally dependent on him. Right, this is the hands-on basic skill colonoscopy course in collaboration with Royal Wolverhampton Hospital, and we are grateful for their support. We use the same syllabus as they do, so if you pay £2,000 in UK and are allowed to do it over there, it's exactly the same course, so you don't have to, right? Okay. Now, the learning objectives, what we want to concentrate on is some basic things like consent, the indication and contraindications for colonoscopy, sedation practice, and depending, well, we probably might discuss diathermy, but we usually hold that till the end, right? So, first and foremost is the consent process. Because consent is not just asking the patient just before the procedure to sign on a piece of paper or scribble something there before you can get on with it. That's not a consent or not a valid legal consent. It should be a proper process. So frequently asked questions about consent: what constitutes an informed consent? What risks are quoted for colonoscopy? What about withdrawal of consent during the colonoscopy, and what to do or not to do, right? So those are the sort of things we will discuss. What are the key components of an informed consent? Informed consent is that when you've given full information to the patient, the benefits, the risks, and the patient is able to retain that information, consider it, think over it, and then take a decision. So the main principles of informed consent are that the patient has sufficient information to understand the procedure, that we explain what the procedure involves, its benefits, and the harms that may arise. And also if there are any alternate procedures that you can do, like a barium enema or a CT colonography. So the patient, in informed consent, the patient is able to understand. That's important. If the patient can only speak Sindhi or Pashto and you give him explain the procedure to him in English, then that's useless, right? So he should be able to understand, retain that information, use or weigh the information given to make a decision, and communicate their wishes. They should be able to discuss it with you, whether, ask you questions and ask you what it would involve. So in that case, the patient is competent to take that particular decision, and according to English law, he has got mental capacity, because the whole thing is whether a person has got a capacity to give a consent or not. Because if they do not have a mental capacity to give consent, then the process is different. Then you do it on the basis of necessity. During the consent process, the patient should not be under pressure or duress or forced into a decision. You should not be especially if you are in the private sector and you want to get a colonoscopy done because you can get, 10,000 rupees for it or whatever, and force the patient or talk him into it, then that is not a valid consent. Patients have the right to choose alternatives. If they want, they can have a CT colonography instead, but you tell them what's the difference between them. Or refuse treatment. Even if the patient has capacity, and if the procedure is in his best interest, he has still got every right not to have the procedure carried out or the treatment carried out. That is his decision, not yours. And they can withdraw their consent at any time. It's not that if the patient feels uncomfortable during the procedure, you cannot force him to continue because you tell him that, oh, you've signed the consent form, so now it is imperative on you to have this done. It's not like that. If they want to withdraw from the consent, they can do it any time, right? So that's important. Useful tips. So whenever you are taking consent from them, ensure privacy during the consent process. It should not be done in a public room or a public place that everyone can hear or overhear the conversation. Follow a structured format for consents, which is we use the acronym EMBRACE, and I'll tell you what it involves. Ensure all aspects for informed consent have been satisfied. Specify clearly risks of the procedure. Always ensure opportunity for question. And during the procedure, it's always a good practice to secure IV intravenous access. So if anything goes wrong, you have got access to the patient's cardiovascular system. So what does embrace stand for? Embrace in other words means hug or jappi. Explanation of the recommended procedure. So you explain to them what the actual procedure involves. You'll be passing a flexible camera tube up the back passage and examining the large bowel or the intestine with it. Motive behind it, why you want to do it, because you want to find out the reason for change of bowel habits or rectal bleeding, or you are carrying out a surveillance for polyps. So the motive behind it, benefits, if they have the procedure carried out, how they are going to benefit from it, that if you can diagnose the condition, you can be able to treat it. The risks involved, the risks that can occur during the procedure, like the complications, alternatives procedure that one can carry out, like CT colonography, barium enema, or nothing at all, on the complications and side effects. Complications again is very much comes under the risk. Side effects are just to complete the embrace thing. Effects is the side effects of the drug that we use, like midazolam or sedatives or analgesics. Now, just one important thing. In British law, and I suspect the same would apply in Pakistani law, is that the actual consent form that you sign or you get the patient to sign is not a legal document. It is not a legal requirement. Even if you don't have that form signed, you can still carry out the procedure. What is important, or what is legally important, is the fact that the whole consent process is completed. That when you see your patient during the first consultation, you document all the patient's symptoms, history, everything. Then you document that this procedure is required. You document that you discuss that procedure, all the indications for the procedure with the patient, and the patient has agreed, and that you've given him all the information. And then you document that you've given him the bowel prep and explained the bowel prep. And if you've done all that and you've not signed a consent form, you have still got a valid consent. So the important thing is the whole process, not just signing of a paper. Signing of the paper just indicates that you've done that, but it is not the only thing. Right. When you are explaining to the patient, because the patient might ask you, what are my chances of getting a perforation or a bleed? So what sort of figures do you quote? Well, it has to be evidence-based. So you have to look at the literature and look at the random complication thing. And if you look at the various series, the figures are different, as one would expect for different series, because they are collected in a different way, or the population is different, or the skill mix of the colonoscopist or endoscopist is different. So the commonly quoted figure is about, yes, the patient can ask you, can I die from the procedure? And if you are going to be very, very truthful, then yes, but the chances are very little. It's usually 1 in 2,000 or something like that. But that's a random population that you are addressing, because they might die of a heart attack or something, like a PE, not necessarily directly from the colonoscopy. So yes, that is possible, but very extremely low risk. Perforation, yes, there is a significant risk. It's about 1 in 1,000. But again, having said that, for diagnostic colonoscopy, perforation in a normal colon is extremely, extremely rare. If you do that, then you are doing it very badly. So if somebody causes a perforation during a diagnostic colonoscopy in a normal colon, then he shouldn't be doing colonoscopies, because that is lethal. But for therapeutic colonoscopy, there is an accepted risk figure, and there is a possibility of causing perforation, and it's more than the general one, because generally we quote about 1 in 1,000, but for a therapeutic procedure about 1 in 500. But if it's a big polyp or a flat polyp, then that figure is much higher. It can be 1 in 200 or 1 in 50 even. Sometimes if I do a very big flat polyp, I usually have the surgeon on alert with me. Sometimes we do it in theater, because the risk for perforation or bleed is quite high. And it is basically, we do it endoscopically because we are hoping to save the patient from a major surgical procedure. So in that case, this is something which you would discuss with the patient in advance. So for much higher polyps or EMR, which is endoscopic mucosal resection, the risk of perforation and bleed is much higher. Excuse me. Hemorrhage. Well, generally, the figure that we quote for hemorrhage is 1 in 500, which is easy. So for perforation, it's 1 in 1,000, hemorrhage is 1 in 500. But then again, it depends on the type of procedure you are carrying out. Taking standard biopsy forceps, biopsy, the risk is minimal for bleeding. Very, very rare. In my whole career, I've only seen one patient who had a massive bleed after a biopsy forceps, and she had antiphospholipid syndrome. So that was an abnormal scenario. Otherwise, even if they are on therapeutic dose of warfarin, we still take biopsies. It doesn't cause any higher risk. But if you are carrying out polypectomy, then there is higher risk, and we should look at what they are taking. If they are taking anticoagulants or antiplatelet agents, then those should be stopped for a therapeutic procedure. The general risk, the standard risk for hemorrhage is about 1 in 500, but if you are taking out big polyps, then the risk is much higher. Now, what happens if your patient withdraws consent during the procedure? What do you do? He said, well, I don't want the procedure done. So, competent adult patients are entitled to refuse treatment. So then, even where the treatment would clearly benefit their health. So even if you think that it is in their best interest and they don't want to have it done, then it's their choice. You have to stop. Well, then depends on what happens. If the patient is unsedated, you've not given him any sedatives, and you decide to stop, then you must stop immediately because he's done it in the right sense. In a sedated patient, endoscopist must act in the patient's best interest because his judgment might be clouded by the sedatives. So you have to take that into account and think that, well, let's see. And in that case, what you can do is, if the patient is getting excessive amount of discomfort or pain, stop, suck out as much air as you can to make it more comfortable for the patient. Take out any loops that are forming during the procedure to make it more comfortable for the procedure. You can give extra sedation if you want, or extra analgesia if you want. Reassure the patient and then restart. And if the patient is happy, then you can continue with the procedure. But if it still insists on and is in severe pain, then you must stop. So in the consent process, what to do and what not to do. So the do's are read the patient's notes. Always a good idea to read the full history and the physical findings. Be familiar with the local protocols, whatever, the consent procedures, the law. Always a good idea to introduce yourself to the patient. At least you should know which doctor performed the procedure and who to contact if there's a problem. Use structured approach to consent, like, the embrace acronym, and check for understanding that the patient has understood what you've told him. And if he does not speak the language you are able to speak, then you should get an interpreter in that particular language so that it is made clear to the patient. Always allow time for patients to ask questions, because that's just simple courtesy. Then don't forget to ensure privacy. Always make sure it's done. Don't use medical jargon. Use common terms. If you do any procedure, any process on a regular basis, you'll be able to do it quickly, smartly, without any problems. But if you do it once in a blue moon, then it will take you much longer to do all this. So normally, if you follow the procedure every time, you should be able to complete all this process in less than 5 minutes, right? And important things are, don't forget to ask about allergies, heart valves, anticoagulants, because they're all relevant. Okay, indications for colonoscopy. Before you carry out any procedure, whether or even if it's a blood test, always ask yourself, is this procedure or test going to change my management? If it is going to change the management, do that procedure. If it's not going to change your management, there's no point in checking full blood count every 2 days. There's no point in checking patients' UNEs or liver function test every week or so. Only if it's going to change your management. So do a colonoscopy if you feel it is going to change your management of the patient. Don't do a colonoscopy just to have a look at somebody's bowel. So always make sure there's a definite indication for a procedure, because this procedure carries a certain amount of risk. And if you cause a complication for an unnecessary procedure, then that is criminal. So always make sure that that procedure is justified. So what are the indications for the procedure? One of the things which I always tell people is that abdominal pain is not an indication for a colonoscopy, whereas I know a lot of my colleagues do it for that indication. Because in abdominal pain, very rarely would you find the cause on a colonoscopy. There are other reasons for it, or other tests that are indicated. Not that you wouldn't investigate an abdominal pain, but imaging is usually more important than doing a colonoscopy. Rectal bleeding is a definite indication for colonoscopy, right? Iron deficiency anemia, again, very important, because in most cases of iron deficiency anemia, especially in men, there is something lurking in the large bowel. And if you normally, for iron deficiency anemia, we always do gastroscopy, duodenal biopsy, and colonoscopy. But I always tell my trainees that if I restrict you to just one procedure and no other procedure, then that procedure you would ask for would be a colonoscopy. Because there's a good chance that the lesion is in the colon, and there's a very good chance that you can cure it. Because with Dukes A, B, and C, colon cancer, with Dukes A, the cure rate is almost 98%. With Duke C, even it is 50 to 60%. So, however, with gastric cancers, resection is only possible, esophagogastric cancers, resection is only possible in less than 10% cases. So statistically, you can do more benefit by doing a colonoscopy, but depends on the symptoms as well anyway. So iron deficiency anemia is a very, very important indication for doing a colonoscopy. Any suspicious appearances on barium enema or CT scan, which CT scan specifically talking about is CT colonography, one must do a colonoscopy, and assessment of colitis or Crohn's disease. So if somebody has got, they are quite common in the West, but they are increasingly common here as well now. Somebody's got colitis or Crohn's disease, you can do a colonoscopy to find out the extent of the disease, to find out the activity of the disease, and to do surveillance. If they've had Crohn's or colitis for more than 10 years, then you do colonoscopy every 2 to 3 years, looking for dysplasia. Now, one thing which I want to make clear is that if you are suspecting somebody to have ulcerative colitis, you do not need a colonoscopy to diagnose ulcerative colitis. You can diagnose ulcerative colitis by doing a rigid or a flexible sigmoidoscopy. You do look, even with a rigid sigmoidoscope, you can do it in your clinic. You find evidence of colitis and take a biopsy, and you've made the diagnosis. You can start the treatment. You can look for extent of the disease later on. You don't have to do it that time, because in acute severe colitis, colonoscopy is relatively contraindicated. So in inflammatory bowel disease, especially if it is ulcerative colitis, Crohn's disease is different, because in ulcerative colitis, the rectum is involved in 100% of the cases. So that's why you can diagnose it on just doing a flexible or rigid sigmoidoscopy. I mean, if you are booked a colonoscopy anyway and you find it, then that's different. You just carry on with it. Yeah.
What's your opinion on if somebody has a flare-up? You know they've got colitis.
Yeah.
And then they have a flare-up.
Yeah. That's a very good question. A lot of the time, you are faced with a situation that somebody comes in the ward with acute severe colitis. You put them on maximal treatment, IV steroids, 5-SA preparations, and even sometimes we use, quite commonly nowadays, infliximab or biologics. And the question Paul is asking, that if you are using toxic drugs, whether you do it on the basis of clinical basis, which a lot of the time we do, or you make a documentation, especially if you are going to start something like infliximab or biologics, then you need hard evidence. And for that reason, you need to do a procedure, but it doesn't have to be a colonoscopy. We usually do a flexible sigmoidoscopy with no bowel prep or minimal prep. Just give an enema, but sometimes I usually do it because they are passing so much fluid diarrhea that you don't need a bowel prep for it. All you need is how bad the colitis is, and it has to be done by an expert. You don't want your trainee registrar to spend half an hour going up to the distal or proximal sigmoid and inflate the patient with air. Because if you inflate too much air, you can cause toxic dilatation of the colon. So it has to be done by an expert with no or minimal bowel prep and just the distal colitis. And I think probably, Paul, that might be your practice as well. So, and sometimes we just do it on a clinical basis if they are passing bloody motions it's more than 6 times a day. So that's very important. Because in that situation, if you do a full colonoscopy, it can be a disaster. Because that colon is really friable, and if you give them a massive, bowel prep, and you inflate it with air, and try to get around to the end of the cecum, then it can cause complications. So you don't want to do that. So further indications: unexplained diarrhea, change of bowel habits to loose or more frequent stool lasting for more than 6 weeks at any age. Anyone, young, old, whatever. Change in bowel habits of any duration, but in patients above 60 years of age, is a definite indication for colonoscopy, and in fact an urgent indication, or anyone greater than 40 years of age if associated with rectal bleeding. Rectal bleeding per se is an indication for colonoscopy. However, some people, if the bleeding is bright red and fresh, would do flexible sigmoidoscopy because it is distal bleeding. A lot of, depends on the personal approach. I tend to go more for colonoscopy because then it's one test which is the gold standard, and once you've done it, you've done it. However, a lot of my surgical colleagues prefer to do flexible sigmoidoscopy, but as long as your approach is right, you do not miss lesions, then that's fine. Screening purposes, you do colonoscopy, there's an indication for doing it for screening purposes, and that is in places where there's a bowel cancer screening program in place. And we do it as part of that, or you do it screening purposes for various high-risk situations, like there's a family history of bowel cancer, or there are certain syndromes like HNPCC or familial polyposis syndromes of various types. You do colonoscopies on those according to the various prescribed intervals. Surveillance for previous polyp, if you've had a polyp resected in the past, then depending on the number and size of the polyps, you would do colonoscopy. In inflammatory bowel disease, usually if they've had inflammatory bowel disease for over 10 years, the risk of bowel cancer is increased, and if they've had it for 20 or 30 years, then the risk is increased quite significantly, and in those patients you would do colonoscopies. Patients who have had ureterosigmoidostomy as a procedure are at high risk of developing bowel cancer, so you would do colonoscopy in those. People with acromegaly are at a higher risk of developing bowel cancer, so in those cases you would do colonoscopy. And another one which I don't think I've put in there, but people with inflammatory bowel disease who have got primary sclerosing cholangitis are at a much higher risk of developing bowel cancer, so they need their surveillance colonoscopy more frequently than the standard inflammatory bowel disease. Now this is important. In what circumstances is colonoscopy not indicated or contraindicated? And the first one is withdrawal of consent by a competent patient. If a patient does not give you consent or withdraws consent, then doing colonoscopy amounts to a physical assault. Endoscopist, then the second one is also very important. Endoscopist not accredited or incompetent to perform procedure, it is a definite contraindication. If you've not been trained to how to do colonoscopy and you just shove the scope in, then that is a criminal offense basically. So you shouldn't be doing it. You should send the patient to a person who is competent to do it. Don't do things which you are not trained to do. Uncooperative patients who are intolerant of the procedure, you cannot keep them calm them down. So in that case, and they can't be safely sedated, don't do colonoscopy in those patients because you can cause more harm than benefit. So in those cases, don't do colonoscopy. You can do them under a GA, but GA colonoscopy again is very high risk because normally a patient would respond with pain if you are pushing too much or causing too many loops. And if the endoscopist is not competent, he just may keep pushing the scope in and cause a tear in the bowel or the mesentery. So if a procedure has to be performed under a GA, let an expert do it for you. Further contraindication, acute severe colitis. You never do a colonoscopy during acute severe colitis. As Paul indicated, you would only do flexible sigmoidoscopy or a rigid sigmoidoscopy with limited or no bowel prep. Toxic megacolon, whoever has got a toxic megacolon, colonoscopy is not your preferred investigation because it can make it worse. Acute diverticulitis, it's a relative or at times absolute contraindication to do colonoscopy because your colon is quite vulnerable and you can cause perforation. Acute abdomen, as I said, colonoscopy is not the preferred procedure for abdominal pain investigation anyway. And this becomes more so important during acute abdomen. Acute abdomen, people with acute abdomen do not require colonoscopy, they require imaging and surgical opinion. Anyone with a perforated viscus, I don't think anyone in his right state of mind would do a colonoscopy in somebody who's already perforated. So the contraindications are, most of them are relative and to be considered with the clinical situation, because always remember that colonoscopy involves three major procedures. One is the bowel prep. So your contraindication depends whether the patient is able to tolerate the bowel prep or not, because it involves taking large amounts of fluid which can cause electrolyte and fluid imbalance as well. So people with impaired renal function or heart failure might not be able to tolerate your bowel prep unless they use some of the more modern ones like movie prep or clean prep. The other thing is how fit are they cardiovascularly and how fit their lungs are, because sedation can cause respiratory depression. So of course that again is a relative contraindication if they are not able to take the sedation, and the procedure and therapy, how fit they are for that. So you have to look at the patient as a whole. Complications, what are the risks of complications? The most dreaded complication that we always dread is perforation, which during healthy diagnostic colonoscopy is extremely rare, as I said earlier. Anyone who causes that should not be doing a colonoscopy. Most perforation occur during therapeutic procedure. But if you are carrying out a major therapeutic procedure like taking a big polyp out or something, then you obviously explain that to the patient as well. And as I said, I've done certain polypectomies in theater with the surgeon accompanying me, though fortunately we didn't need their services, but still always a good idea to be prepared. Weakness in the bowel wall, for example, diverticular disease, extensive diverticular disease can put you at a higher risk of causing a perforation, especially if you are careless in inflating too much air. Severe colitis, the bowel wall is friable, thin, and stretched out. So it's easy to cause a perforation there. Factors affecting outcome during perforation. If the bowel preparation is poor, it will make it worse. If the patient is elderly, frail, and have got other comorbid factor, then it makes the outcome of perforation poor. The other important thing is recognition of your complication. If you feel at any stage after the procedure or during the procedure that you've caused a perforation or a complication, don't try to hide it. Don't push it under the carpet, because it will never go away. If there is a perforation, it will show up. And if it shows up later, it will cause more problems. So it is better to recognize it early and treat it. If you suspect that the patient is getting excessive amount of pain or become peritonitic after your procedure, I always would admit that patient, do an abdominal x-ray, get a surgical opinion, because nobody is going to blame you if you've done all that. Because perforation is a recognized complication in colonoscopy, especially if you carried out a therapeutic procedure, and if you've taken all the correct procedures for it, then nobody can blame you. However, If you try to hide it, send the patient away or disappear yourself, then that is criminal. Bleeding, again, a possible complication of the thing. Approximately 1% of post-polypectomy bleeding can occur immediately, and you can, if it occurs, when you are carrying out the polypectomy, it's easy. You know where the bleeding point is, and you can easily seal it off straight away. So that's not a problem. However, it is very well recognized that a significant number of patients come with post-polypectomy bleeding after several days, and you see it even after up to 10 days. And this can occur not just with polypectomy, but after sphincterotomies and other things as well. So be prepared for that, or warn your patient that at any time you start feeling dizzy or start passing blood, then you should come to the hospital. So always warn the patient of this possibility. Like some polyps are big, or if they are flat, or if they are in a difficult position to access, then only attempt those polypectomy if you are good at it, if you are being properly trained. If not, send it to somebody who is an expert. Because if you start causing bleeding and the polyp is difficult to get at, then you won't be able to stop the bleeding. Secondly, don't carry out a procedure if you do not have the proper equipment available. Always carry it out if you got all your equipment available to stop bleeding, like clips, loops, APC, gold probe, whatever you are using, or hemospray nowadays. And your nursing staff or endoscopy staff should be familiar with their use. If they are using equipment after, say, 2 years, they might not be familiar with how to use it. Another important thing, bowel prep, what to give the patient, because you need to have a clean bowel so that you can examine the bowel clearly. Bowel prep can cause electrolyte imbalances excuse me, and can cause renal injury, especially when phosphate-based products are used. You all know that during chronic kidney disease or acute kidney injury, there is always hyperphosphatemia, hypocalcemia, hyponatremia, hyperkalemia. All those can be made worse by your bowel prep. And because of the fluid shift, the bowel prep can cause potentially hypovolemia, and especially if that occurs in an elderly patient, they can become quite hypotensive and can feel dizzy and can have falls. They can cause hyponatremia, hypokalemia or hyperkalemia, hypocalcemia, and hyperphosphatemia, because most of these are, the Picolex is phosphate-based or fleet animal. So be aware of this. So it's always good that you assess your patient before you prescribe the bowel prep. In case they have impaired renal function or impaired heart function, then one should use clean prep or movie prep. In our department, we give movie prep to everyone, so we are quite safe in that respect. The problem with movie prep is it involves drinking over 2 liters of fluid, which is foul tasting. It's horrible to take, but it works very well. It's very effective. Colonoscopy is regarded as a gold standard investigation for investigating the large bowel. And even in expert hands, there is a certain miss rate, which may be lower in the better skilled people, but still you can have a pathology or miss a polyp in up to 5% of cases. This is a sort of gross average. This is less with people who are more experienced and skilled, and more in the novice, especially people who just withdraw the scope very quickly. So the patient should be warned in the consent process that there is a possibility we might miss pathology, which means that if they get, even after the procedure, they get rectal bleeding or subsequent change in bowel habits, they should be reassessed. They shouldn't be told that, well, we've got a normal colonoscopy, forget it. So always think of first do no harm. That's the basic principle, right? So of your ethical framework. So due to the potential to do harm, individual risk assessment is always required before colonoscopy. Patients who are elderly, frail, are at high risk of complications, with especially those who have had heart conditions, chest conditions, diabetic, with peripheral vascular disease. They all, people with chronic respiratory diseases, with chronic kidney diseases, have a higher risk of complication and mortality from colonoscopy. So, and again, higher risk associated with fulminant colitis, previous radiotherapy. So always keep that in mind. Women who've had previous hysterectomies are more challenging to do. So if that is the case, then always put them on a list of somebody who's good at doing it, because it can be a nightmare. There are adhesions, the colon is tethered, there are sharp bends, so you might find it difficult. Patients with bleeding disorders are those who are on anticoagulants. You should be aware of. You should be aware of any allergy to sedatives, because if they are allergic to sedatives, you should avoid using those sedatives or drugs, because there's no point in causing unnecessary anaphylactic reactions on the procedure table. Patients who have diverticular disease, you have to be careful that you don't go through the colonic wall. Clinically unstable and uncooperative patients, you should be selective in your patient. And at times, especially if the patients are elderly frail, I usually compromise by sending them for a CT colonography. Why risk colonoscopy when you can avoid it? So always good to do that. Right. Shall we take a break, or you want to continue? Get on with it, yeah. All right, okay. Get rid of the boring stuff, yeah. Okay, fine. Sedation. Again, very important, because it is good that the patient is sedated and relaxed, but it is equally important that that is done safely. And in medicine, it is very important, like in everything else in life, whether it is politics, social affairs, whatever, that there should be, our financial affairs, there should be a regular audit of your procedures. Because when there is no audit, there is corruption, whatever field of life it is. So in UK, in our medical practice, we audit everything that we do. So whatever procedures I do, Paul does, irrespective of how skillful he is, his data, everything is audited. My data is audited every year, and then I'm sent an audit report that how many procedures I did in the year, what was my completion rate for colonoscopy, what was my polyp detection rate, what was the amount of sedation I used, both pethidine and midazolam. So, we use fentanyl nowadays. So everything is audited, and my complication rates. So they are all, because all our procedures are recorded electronically, so they are very easy to pick up. So everything should be audited. So the National Confidential Inquiry into Patient Outcome and Death report in 2004 on therapeutic endoscopy judged that 14% of cases had been over-sedated. I think this is a rather conservative figure. Practically working in an endoscopy department, and I'm sure Paul would agree with that, that the rate of over-sedation was far more than that we used. I mean, some of my surgical colleagues used to belt in 10 milligrams of midazolam and 50 to 100 milligrams of pethidine and carry on with colonoscopy. So the problem with that is the patient is flat, but then sometimes they don't wake up. And that was one of the major risk factors for complications, because it just gives you a more cavalier approach. You just keep on doing it, even if the patient, because they can't struggle with you, so more risk of complication. So this was one of the things that was picked up, and it was very much sort of highlighted, so much so that we've gone to the other extreme now, that people use very minimal sedation. But then again, if your skills levels are good, you wouldn't need a lot of sedation. So this is where it was highlighted, the risk of uncontrolled sedation. So sedation is important, but it should be carefully controlled. So what are the main risks? You all know that most of the sedatives, the hypnotics, the analgesics that we give, the opioids, they cause respiratory depression, which is hypoxia, CO2 retention, can result in aspiration pneumonia later on because they cannot protect their airways. Some of them have a toxic effect on the heart muscle or the cardiovascular rhythm, can cause hypotension, hypertension, vasovagal effects, and other reactions which are, memory loss, nausea, vomiting. So what risks do you normally discuss with the patient? You can't give them a full, list of. So the main one that you discuss with the patient are depend on what their comorbid, their status is. So generally, it is important to assess their medical and surgical condition first. So you mentioned mainly about respiratory depression and need for monitoring, that you would be checking their O2 oxygen saturation. We normally check their blood pressure during the procedure, and their pulse blood pressure is regularly monitored. Some places they do ECGs as monitoring as well. We don't do it in normal procedures. You can tell them about nausea, vomiting, memory loss, especially with midazolam, and also reassure them that reversal agents are available. However, nowadays, if you use reversal agents, it is used as an adverse event. So a DATIX form, an adverse event form, has to be filled in our department, because that means that you use too much sedation. Right? So, so that is something which discourages us from using it. Well, not discouraging us from using the reversal agent, because that should be used when it is needed, but from over-sedating. So what are the common, I think over here it's a bit different, but midazolam is our main sedative hypnotic agent that we use, which is used here as well. So there's no difference in that. Whenever it is usually for colonoscopy, we use it in combination with a painkiller, which is, we tend to use fentanyl or pethidine. Over here they use nalbuphine, I think. Yes. Yes, yeah. Right, so they are. So the thing about midazolam is that it has a longer half-life, and onset of effect takes 3 to 4 minutes. So it's not that as soon as you give the sedation, it is better to wait for some time before you start. Or you can start and, so if the patient is awake when you give the sedation, it doesn't mean that he's going to be awake, so don't give too much. However, if it is given with an opioid, then the onset of effect is much quicker. So normally, now that is all clever stuff, so you don't have to remember any of that. But just be sure that the effect of midazolam is more so in patients who are obese, right? The effect is more pronounced in patients who are elderly, and it is more with people who are got cardiovascular, congestive cardiac failure, liver or kidney. So all patients with comorbid factor would have more effect from the sedation. And those are the patients who would suffer more from the effect of hypoxia. So elderly patients, so our cutoff point for elderly is 70 years of age, but then it depends on your patient quality as well. You may have a very good, fit 70-year-old, or you may have a totally, crumbling, 50-year-old. So depends on, if your 50-year-old is very frail, then and very unfit, has got chronic obstructive airways disease, then in that case you would treat them like more than 70. So the general recommendation in UK is that the maximum dose of midazolam is 2 milligram in patients above 70 years of age. We don't give more than 2 milligram, and that's it. Maximum dose in younger patients, we give not more than 5 milligram in younger patients. If they don't get sedated with that, we don't go any further, it has to be reconsidered. So that's it is something which can, affect your cardiac output, your blood pressure, your respiratory, and nowadays it's considered as a controlled drug in Britain, so it has to be signed for, right? So treat it with respect. The opioids that we give are either fentanyl or pethidine. The effects are very similar. It's a general opioid effect. Given in combination with midazolam, it has a synergistic effect. So the effect is more pronounced. So you have to keep that in account. Again, the maximum dose of pethidine is 50 milligram for any patient. Maximum dose of fentanyl is 100 micrograms for any patient. And that has to be reduced by 50% in patients over 70 years of age. So people who are elderly, they shouldn't be given more than 25 milligrams of pethidine or 50 micrograms of fentanyl. That is their maximum. Whenever you give them in combination, you give pethidine or fentanyl first, wait for a minute, then give midazolam. The reason for that is that if there's going to be any respiratory depression or anything, you would only have one drug on board rather than two. But if you give two of them and they suddenly stop breathing, then you got a bit of a problem. So if you've only got one drug on board, then it's not such a big problem. Secondly, the effect is synergistic then. It gives better effect, right? It is lipid soluble, is associated with increased rate of nausea and vomiting like any opioid. And sometimes when you inject pethidine, it causes histamine release and you see red lines tracking along the veins. So that is because of the local effect of pethidine. Reversal agent, as I mentioned earlier, the use of reversal agent is a proxy for over-sedation and is an auditable outcome on our GRS, which is the global rating scale. Reversal agent is flumazenil for benzodiazepines, which, if needed, is given over 200 micrograms over 15 seconds, then 100 micrograms at 1 minute interval. You just see the response of the patient if they need more. Naloxone or Narcan is an opioid antagonist, and you give it 0.4 to 2 milligram. But always keep in mind that it has got a very short half-life. So if you've given somebody a long-acting opioid, they need to be monitored and given this repeatedly. So for procedures like colonoscopy, ERCP, and upper GI endoscopy, the sedation we give is known as conscious sedation. Conscious sedation is that the patient is not knocked out, the patient is able to talk to you, and we tell them that you will feel as if you are heavily drunk. Now obviously you don't tell this to your patients here because it is not the done thing. So, and you can get yourself into trouble. But it is something which is, that they feel drowsy, but they are awake, they can talk, but they wouldn't remember what they say. Normally, during the procedure, we, as a habit, continuously talk to the patient. Or sometimes, if I'm a bit lost in the procedure, the nurse would always be talking to the patient. And it is very important because the moment you lose verbal contact with the patient, that is the moment to be alerted. It is more sensitive than your even oxygen saturation, drop in oxygen saturation, because that is when the hypoventilation starts. When the patient loses verbal contact with you, they don't respond to your verbal, prompts, then I think they are over-sedated. The other thing which obviously you monitor is their oxygen saturation. So you've got a pulse oximeter, and if there's any drop on that or the alarm starts ringing, then you should be alerted. You should stop your procedure and look after the patient. So, appropriate sedation, it is very important to know the difference between appropriate sedation, over-sedation, and under-sedation, which is a continuum from desirable anxiolysis and antegrade amnesia to a patient anesthetized in an unprotected airway. So you don't want to reach that stage, right? So it is always necessary to keep regular and frequent verbal contact with the patient. And the nurses or the endoscopy assistants should be well trained in that. They should, So repeatedly check the level of sedation. The starting dose, always start with minimal dose. You can always try to it up. If they need more, just give more. But you start, sometime you'll be surprised that you can carry out the whole procedure with just 1 milligram of midazolam and 25 of pethidine or 50 of fentanyl, and that's usually enough. So don't give too much from the start. When should reversal agents be used? Well, recognizing respiratory depression, it's always, they all cause drop in oxygen saturation and retention of carbon dioxide, which may lead to apnea or respiratory arrest. So observation of ventilatory effort, if the patient is breathing normally, the nurse observing him is happy, then that's fine. Pulse oximetry is a sensitive measure that we have, but it doesn't measure the ventilation. So loss of verbal contact is often the first sign. So always use that. If you feel that the patient is over-sedated, always try to stimulate the patient, talk to him, call out his name loudly, and see if they would breathe more, encourage them to breathe heavily or deeply. If not, then in that case, use the reversal agents, protect their airways, consider, calling the crash team earlier rather than later. You don't want to leave it too late. So if you call the crash team or the cardiac arrest team, you'll have more help available with you. So forget about your procedure and look after your patient. Right, so when you are giving sedation, it is standard practice in the UK, and it should be here and it should be everywhere, that you should look, normally in our department the nurses drop the sedation for us, put them in the syringe and label the syringes. But in spite of that, we still look at the ampoules of the drug that they've drawn up. So you look for the name of the drug and you call it out loudly, that midazolam, 1 milligram per mil, 2 mils, and you also read out loudly the expiry date of the medication, like end of 05/2017, right? And the nurse repeats it with you. So it's a double check. Before you give sedation, always wait that the pulse oximeter, the blood pressure have been attached to the patient, and you got a baseline pulse oximetry reading, you got a baseline pulse reading, and you got a baseline blood pressure reading. Only after that give sedation. Don't give sedation straight away, because you wouldn't know what the patient was like before you did anything. So always get a baseline before you give, because sometimes people are in a rush and they would beat the nurse to it. As I said, the midazolam would not start working straight away, and you would get the effect after a few minutes. So don't feel that if the patient is not knocked out straight away after your injection, you need more sedation. Wait for it. Work as a team with your nursing staff and our endoscopy assistant for ensuring adequate monitoring. If your nurse is not happy with the patient's condition, listen to her and act on it, and keep in regular verbal contact with the patient. So if that you do it, or sometimes the nurses are good at doing that. Now, always give pethidine or opioid before the midazolam, so don't give midazolam before. Don't forget to continue to monitor observation throughout and after the procedure, and always believe in the alarms. Don't think that, oh, it's a faulty equipment. So if the alarm is going off, act on it. Don't ignore information given to you by the nursing team relating to vital signs. If they feel that the patient has gone blue or is not breathing, stop your procedure. Look after the patient first, because it is more important that you have a live patient at the end of the procedure rather than a completed procedure on a dead patient. So the other important thing is, if the O2 sat drops, the answer is not increasing the oxygen flow. Because sometimes people say, oh, how much oxygen is on? 2 liters per minute, or increase it to 4 liters or give 10 liters of oxygen. That is not the answer. See why they are dropping their oxygen saturation, right? If it is over-sedation, giving too much oxygen would make it worse, because it will result in more CO2 retention, especially in patients with. So Those are the do's and don'ts. And
Okay, could I just ask you to go to the previous slide?
yeah.
Can I ask the previous one to this on here there is an important point. When is the patient most at risk from the sedation? See, who's on there?
At risk for hyperventilation. Any issue.
When's the patient most at risk from the issues that sedation can give?
Probably yes will do.
When you give slow doses, more often than
In the start of the procedure.
drug acting at one single point. That time it really seems that ventilator was sinking.
At what point in time, and the procedure as a whole, from the journey that the patient comes in to the patient going home, what point in that time is the patient most at risk from sedation?
And then the procedures mid-time, and we're trying to transfer him towards a special care or emergency unit where we need to observe him. And then we have a downfall and there's no oxygen or that's the only time.
The biggest thing is on here, it's top line, stimulate the patient to wake. Now the issue, the patient's most at risk from sedation in recovery. Because they're no longer got a tube, they're no longer being talked to, they're being allowed to rest, and that's the time that they're most at risk from sedation.
I think the other thing is, which you made a good point, is when the patient is transferred to special care units or ITU, normally, can I stress this point, that our patients are not transferred to ITU or special care units. If that happens, that is very bad news. It would reflect very badly on me. Normally, our patients are recovered in a recovery room or a recovery unit, which is got very basic level of nursing staff there. I mean, they're very good, but it's very basic level of nursing that they get, because these patients actually wake up and walk home sometimes, or they're carried, like, they are driven home if they've had sedation. So your endoscopy recovery should be very low key. It should not be a special care unit. If you are sending your patient to special care unit, that is bad. Right. Okay, you've been a very good audience. I only saw a few yawns, so it wasn't too boring. So thank you very much for your kind attention, and we'll carry on. This is the end of the boring stuff. We'll start off with more practical stuff. This was important to convey the message. Always keep, I think they might give you handouts of the slides, so you can go through that. Always a good idea to keep those things in mind and implement them in your unit. Enjoy your tea break, and we'll resume later. Thank you. Yes, sir. Go on. Yeah, go on. Yes, sorry. Should let you ask questions. Yes, go on.
My question first is that how we already debated from patients having deep conscious versus conscious sedation. Deep sedation versus conscious sedation.
Yeah.
Conscious sedation is the best sedation.
Yeah.
What about the patient having both sedation and colonoscopy? Is that the best thing to have it?
Yes, I mean, I think this is Paul's practice and mine as well. Majority of our patients for colonoscopy, I do not give sedation. And I think, Paul, yours is don't have sedation. So I hardly ever give sedation.
Because I think the patient in conscious sedation is difficult to handle rather than a patient without sedations.
Yes.
Because you need a more manpower to handle that semi-conscious patient.
That's right. I mean, we should have that in any working, a good endoscopy unit. People should not be forced not to have sedation. I mean, it is their choice. You explain to them the benefits of having sedation, not sedation, and give them the choice. And you also give them the choice that if they feel uncomfortable, that we'll give them sedation if they need it, or sometimes we give them gas and air, which is nitrous oxide. So with that proviso, and when you give them that option, they would go for it, and most of the time they do not require it. But yes, I mean, other people in my department give much higher level of sedation, but I give, majority of my patients I do without sedation.
Okay.
Yeah. But this is, I'm giving a general sort of talk that, what to do.
My second question is it routine to give antispasmodic to the patient going for colon to improve our field of vision and we don't encounter more loops because it costs.
It doesn't do anything to loops, that is one thing. Giving antispasmodics, probably it might make it worse, because the colon is more relaxed. Some people give it routinely. I do not give buscopan routinely. Some people give it on withdrawal to improve, like what you mentioned, the field of vision.
ADR rate will be.
Because one of my colleagues did a paper on it, and we found that the polyp detection was better. But if your technique is good, it should be, your polyp detection rate should be good anyway. The main thing is that when you are withdrawing your scope, you should not rush it. We recommend that when you start withdrawing your scope, you put the timer on, and you should not do it in less than 6 minutes. It should be more than 6 minutes, right? So the more the better it is. So that is important. Yes, I mean, there's no, if you prefer to give buscopan or antispasmolytic, you give it. I wouldn't, argue with that. I don't know, Paul, do you give it routinely, or I never give it routinely. I only give it if needed. Regarding loop resolution, buscopan doesn't help that. It is over inflation which causes loop formation most of the time. Sometimes you can get it anyway. It's a personal preference whether you give it or not. Yeah.
Okay. And my last.
There are some people who give it at the beginning because they believe that the sigmoid is very tight and painful, so they will give it. The issue about giving buscopan at the beginning is that it makes the valve very lax.
It just flaps.
More air in, you put more scope in.
Yeah.
The idea about giving the buscopan at the end, it makes it more relaxed and you can move the patients around. I tend not to give it because I actually find that if you just nice and steady coming back, the actual movement of the bowel makes the polyps
More visible.
Going back a little bit to one of our slides, when you're consenting a patient, how many of you in this room consent a patient for missing something? So do you consent patients on your form, do you say the chance of this procedure of missing a lesion is X? You say that?
Never. Actually never.
What do you think the actual miss rate is?
5%. 5 to 10%.
So do you think you have a responsibility to tell the patient?
Yes, honestly, yes, it has to be.
So, and what I'm saying to you is, now if I put it back and we say 5%, 1 in 20 of your patients, you will miss something, or you won't see it. Now, I have spent 20 minutes in the secum, taking off a large polyp. I reported on the CT scan and reported on previous colonoscopy. I spent 20 minutes taking it off. I come back, let the bowel settle down, went back, and another polyp appeared to the left. And I was there for 20 minutes. So what I'm saying to you is, regardless who's doing it, you cannot see something all the time. So, getting back to consent and miss pathology as well. Consent for your bowel care. So the journey of consent includes all these things. And the more drugs you give, the more problems you cause. So as a result, any drugs that I give very minimal. I'm very cautious about what I do, and that's why I don't do it.
Thank you. Last more question. Normally when we scope for certain indications, especially like being a surgeon, when we scope, first indication would be the low GI bleed, right? The fresh low GI bleed. In pediatric population, we don't have indication why the child is having low GI bleed, but we have always a polyp at the back of our mind. So our first instinct to going the scope inside is to have a diagnostic intention. If we find a lesion, do we need to do intervention at the first setting, or we need to arrange it in a second? That means putting a soap next time with sedation in a pediatric patient.
I think if you do any procedure, you should be competent to carry out treatment as well. Now, normally you carry out treatment if it is safe to do so. Like if I do it in an adult, I would always go with the intent of treating the bleeding, not just for the hell of, just for looking where it is. Because if I can treat it endoscopically, I'm saving a major surgical procedure and exsanguination of the patient. So whenever we go in, we always go with the intent of treating it. If it's a polyp which is bleeding, we'll take it out and seal off the bleeding point. If it's a diverticular disease, you can seal off. So whenever you do it, always do it with the intent. Yes, fine, if it's a very big polyp, you can't take it out, then you look at other things and you re-consent the patient. But generally, because if you carry out an additional procedure, you are putting the patient at additional risk. Secondly, in lower GI bleeds, I'm talking about adults because I have no pediatric experience myself, the common cause, like in diverticular disease, lower GI bleed, they stop spontaneously. It's a one-off bleed, you resuscitate the patient and then it doesn't occur again. So that's fine then. But if it is continuous bleed, then you should find the bleeding spot and treat it.
Doing the scope, you find the bleeding points and fix it with the APC and all that? Yeah. Or for that, this patient, second procedure, they need angioembolization most of the time with the massive lower GI bleed, and you can't see anything on the scope.
No, I mean, the
and
thing
you become
is,
incapacitated in that
when you are doing a procedure, you should do it when you are able to see. You shouldn't do a procedure when you can't see, because you can cause more harm than good. Like, if the patient is bleeding actively and you can't scope them, then you should do a mesenteric angiography, because with active bleeding, that is a better procedure. You can actually see where the bleeding point is, and if you've got a good interventional radiologist, he'll embolize the bleeding point for you. Either, embolize it with coils, and it will stop. So that's what, because mesenteric angiography for bleeding is only effective if you are standing in a pool of blood yourself. So if you can't see, you shouldn't do a colonoscopy, because colonoscopy should only be done. Would you agree with that, Paul? Yeah.
The issues that you have, I think what you're asking is, you go in, you look at the reasons why you're doing the test. So you need to know what the reasons are. What are the common causes, what are the common pathologies that you will find that will cause that issue? If you've got PR bleeding, it could be a polyp, it could be a cancer, it could be inflammatory bowel disease. So you'll want to take biopsies. If it's a polyp, you'll want to remove it, depending on what type of polyp it is. If it's a flat sessile one, that needs lifting. In the UK, we bring them back because the complication rate is higher. So I would not take off an EMR at this time. Straightforward polypectomy, even if it's 3-4 centimetres, I would take off at that time. The issues that we have in the UK is that we have a specific band of time to do procedures. So have you got enough time, once you started, to finish? And if you haven't got enough time, then don't start, then you are forced to bring the patient back. What we can't do is bring a patient in that you said I'm going to do a diagnostic, or found a polyp, I am now going to take the polyp off. The patient cannot give you consent because that's coercion, because you're achieving things. So you've not got the right consent in place in the first place, you haven't done that part right. So it depends on what's in front of you, and that's what you need to play with. And if it's a reasonable polyp, you can take it off if you consent. The issues about pediatrics, that's again slightly different, and we tend to be a lot more cautious. In the UK, in the last year, they've only just started the first official pediatric colonoscopy course, exactly the same course, but aimed at pediatrics. So it has a different way of doing it, so they include the anaesthetists, and that's where that comes on. All the children in the UK are under anaesthetics. And so in the UK, the same course for pediatrics. Whereas a lot of pediatricians don't tend to attend courses, they tend to call on an individual basis to back out on myself, so it's actually learned it, they're not competitive. Now in the UK, they have to attend pediatric course. That's what we just started.
One thing that has bothered me from the beginning, so the basic difference, I believe I'm loud enough. I get a very loud voice on the move.
Right, okay.
The basic difference between the patients out there in the UK or the US and our patients is the level of understanding, the literacy rate, as Dr. said.
Yes, sir.
So would that be justified to explain them all the risks of what we can put them into and expect them to understand? Would it be logical to do that? But what happens with us is, if we take the patient, we sit down with him and we explain to him the risks and the benefits, he runs off.
I think my answer to that would be that when we are dealing with a lay person in UK, their understanding is very similar to what your understanding of a lay person here is. They are not highly qualified. No, none of them, most of them do not have university education. So they may be just equally. So the main thing is the amount of time you spend with your patient and the amount of information and the quality of information that you provide them. We provide them with information leaflets. I mean, fine, if they're illiterate, they won't be able to read that. But as I said throughout, that when you are doing it, you should make sure that you are explaining your procedure in simple, non-technical terms. If the patient does not understand Urdu or English, you should explain it to them in their local language through an interpreter. Like if he speaks Pashto or Punjabi or Sindhi or whatever, Balochi, they should have, I mean, that is their right to know. It is not right to deny them the information just because they are illiterate or they are, of poor understanding.
Is it ethical? That is
it is ethical, absolutely, yes.
Can I tell you a story, a real story? Happened here my first visit.
Yeah.
Right. Now, I've been doing colonoscopy for 30 years. I'm not going to tell you how many I've done, but I've done a fair few. The issue came on the first course is that there was a conference where, projected back to this room, there was procedures being done. They had a child, 12-year-old child, and the child had a very large polyp back, I will tell you this. There was a guy over from the United States, gastroenterologist, very famous gastroenterologist, and he agreed to come with me and we saw this child on the morning. Projected back in. Went in, I saw this polyp. This polyp was roughly the size of this. And that's no lie.
Bigger than this.
It was big.
Yeah, so it was seriously big.
So, judging by your accent, probably you understand the Americans better than I, and their sense of humour. So anyway, this American turned, I says, what do you think? And I says, back in the UK, I would not take this polyp off. This is projected back to here.
And in fact, I asked Paul, I said, would you do it in your department? And he said no.
No. I said, in the UK, I would then give it to my surgeon, ask them to take it off. What do you think? And the American turned round and he said, I concur. I always love it saying this bit. Why can't he say, I agree? So yeah, I concur. So I didn't do it. I took the scope out. I came back to the room and everybody was quiet. Everybody, we expected you to take it off. I said, well, we shouldn't mess with our future. I said it in very blunt terms. And our children are our future. And they says, well, surgery in some hospitals isn't very good, so, it would be best. I said, well, I'll consider doing it if I talk to the father. Now, coming back to your point, this father was not an educated man. Okay, he was a normal man looking after his daughter the best way he could. And what he said through somebody I trusted, this is the most important thing when you use a translator, someone you trust. And what he said was, if you don't do it, she'll need an operation, and they may not do very well. If you do it and you're successful, she don't need an operation. But if you do it and something goes wrong, she'll need an operation anyway. And that's an uneducated man. So I went back to the UK, and when I take off big polyps, I say, if I don't do it, and an uneducated man taught me something. So.
I'm not degrading. I was just asking that, is it ethical if we are voluntarily holding back a few things?
It is ethical, it is their right to know. You cannot be involved with them. One thing you are not just if you have education, you cannot I sometimes felt bad about it. No, the thing is, all you need is, you need to be honest with them and give them the facts. Then it is up to them whether they want to go for it or not. Sometimes, and in UK also, because I work in I created those communities in the farming community, and they are very much simple, I'm in North Wales, which is a very rural population, and they are very simple farming people, and they would tell me, oh doctor, you know best, just do whatever you like.
That's the usual answer.
But that is the usual answer, but that doesn't mean that I do whatever I like. I still sit them down and I tell them that, look, yes, fine, you trust my judgment, I feel flattered, but this is the real situation. And then they still tell me that, well, do it or don't do it. But it gives them the right to decide on the basis of the information that you have provided at least tomorrow if anything goes wrong, in the court of law you can stand up and say that I explained the procedure to them, I gave them the full option, he decided, that was his decision, not yours then. So yes, but you have to give them the full figures, what in your common terms, like, you know, that man is a classical example what Paul just quoted. He even educated us. So, yeah. Yeah.
So I told that my surgeons, and my surgeons now come back and they say to patients.
So it's always, you know, that is part of the, like, you know, if you look at the ethical framework, the first, you know, thing about framework that first do no harm, then, you know, always do good. Then the thing is, like, there is independence, and there is the patient, you know, the patient's will, which is, so that takes precedence. The patient's own independence or will takes precedence over their best interest. In the West, even if it is in their best interest and the patient refuses to have treatment, then that takes precedence over the best interest. So you should respect your patient's wishes.
And if you're asking, if I have somebody who can't consent in the family, here it's slightly different in the UK. What I tend to do, how I word it is, if your mother or father could say to me now what they would like to do, what their answer be, you think. I don't have to. I know what your answer is. I know what you want me to do. And what would their answer be? You know them better. So there's a ways of asking.
Any more questions? Very rarely.
What I use instead of antispasmodics. Anything else you can use instead of antispasmodics? Glucose, you can give an injection of glucagon. Anything else? What is the most effective thing that you can use instead of an antispasmodic?
Warm water.
What else?
Warm water. Warm water.
Yeah.
Don't over-insufflate.
Yeah.
As soon as you come across, what happens when you over-insufflate? It always dilates proximally in your ear. A bit of warm water, leave it, go. Relaxes. Cold
Yeah.
water, spasms.
Yeah.
So warm water.
Right. Good. So now relax, chill out, and we'll carry on.